Okay, let's talk about this cool case of acute compartment syndrome following a major polytrauma. So this is a 23-year-old male who presented via EMS or ambulance after a motor vehicle crash. He was very tachycardic. He had a soft blood pressure and he was mentating well. He was noted to have significant trauma, including bilateral lower extremity open fractures. He was intubated immediately upon arrival. His EFAS was negative. We're going to focus on the right lower extremity where he had an open ankle fracture dislocation. The trauma surface measured the compartment pressures of the leg, and the anterior and posterior superficial compartments were both dramatically elevated. The patient went straight to the operating room for an emergent surgical fasciotomy. Prior to getting to the operating room, he was also noted to have a right radius fracture, a right tibial plateau fracture, and an L3 chance fracture. Let's talk about acute compartment syndrome. Essentially comes down to the intracompartmental pressure exceeding the arterial perfusion of the compartment. The incidence is 1 to 7.3 per 100,000 cases. Trauma and fractures represent the vast majority, with tibial shaft fractures being the most common culprit. It's more common in men than women. They like to do dumb things. So here is the post-splint x-ray of the right ankle of our patient who went to the OR. You can see a large distal tibial metaphyses fracture. You can see a midshaft fibular fracture. You can see the ankle joint is completely obliterated. The talus is sitting laterally and is not articulating with the tibia, the fibula, or the calcaneus. There's probably also multiple foot fractures there, but you can't really tell in this view. So let's talk about the pathophysiology of acute compartment syndrome. Essentially, blood flow does not meet the metabolic demands, and subsequently there is tissue ischemia. A cascade of events, including inflammation, arterial spasm, disrupted capillary flow, increased osmotic pressure, proteinaceous exudate, muscle fiber, swelling, and edema occur. This is like a self-propagating cycle, which further increases the intracompartmental pressure. And without surgical decompression, irreversible ischemia and cell death will occur. On the right, I have a little table which shows the causes. Starting at the top, orthopedic would be most common. Tibial fractures, also blunt or penetrating trauma, and total knee arthroplasty can precipitate this. In the vascular area, you can see reperfusion therapy, arterial punctures, hemorrhage, DVT. Soft tissue would include a crush injury, contusions, burns, or envenomations, and then iatrogenic as well, anticoagulation and bleeding disorders, casts or splints, constricted dressings that are too tight, extravasation or third spacing of drugs and fluids, sitting in the prolonged lithotomy position for too long, viral myositis, and diabetic muscle infarction. So here's a cross-section of the lower leg, which is useful to review. Essentially, it can be broken down into 4 compartments. Starting anteriorly, you have the anterior compartment, which is A, which has the deep perineal nerve, responsible for dorsiflexion. You have the lateral compartment, which has the superficial perineal nerve and responsible for plantar flexion and eversion primarily. And on the back side of the leg, you have B and D, which are the deep and superficial compartments respectively, which have the posterior tibial nerve and posterior tibial artery and are responsible for plantar flexion. So any 4 of those compartments can be involved in acute compartment syndrome. So how's it diagnosed? Well, the truth is it's primarily clinical with pain out of proportion to exam. You're going to have tender swollen compartments, but that can be delayed, it can be missed due to distracting injuries, and therefore requires a high index of clinical suspicion. Most textbooks talk about the 6 Ps of compartment syndrome, which are not universally present in any given patient, but worth reviewing. Pain is the most common initial symptom, paresthesias in a sensory distribution, pallor, paralysis, which is loss of motor function, pulselessness is a late ominous finding, and poikilothermia is like a temperature or color change. Temperature or coolness felt within the affected extremity. Compartment pressure, okay, this is how you objectively measure acute compartment syndrome, although again, it's typically a clinical diagnosis. Stryker is the most commonly used brand. Normal compartment pressure would be less than 20. There's some subjectivity there. Pathologic is considered greater than 30, which again is somewhat subjective. Higher pressure accelerates damage, so like 40 is not as bad as 50, is not as bad as 60, etc. Delta pressure is diastolic pressure minus intracompartmental pressure and may be more accurate. And if that delta is low, it suggests acute compartment syndrome. It's also worth checking some labs, at least specifically for this disease process. You're probably going to get other labs in the setting of trauma. But that includes a CK and a urinalysis for rhabdo, and then looking for creatinine and potassium for kidney dysfunction and cellular lysis. So how do you manage it? Well, the bottom line is it's a surgical emergency. Treatment is a fasciotomy, and the time to OR matters, with greater than 8-hour delay associated with permanent injury. The decision to non-op a patient will be rare and made by the surgical team. And in those patients, you should remove any splints, casts, and compression devices, which can reduce the intracompartmental pressure by up to 2/3. Early or acute complications include rhabdo, hyper-K, sepsis, multi-organ failure, loss of limb, and even death. And more chronically, foot drop, contractures, paralysis, delayed amputation, chronic pain. And so in our patient, he went straight to the OR. He had a lot of surgeries. On that right leg, he had a fasciotomy, subsequently X-fix, debridement, irrigation, and eventually the surgical team decided to amputate that leg. This left leg, he had an X-fix and a tibial talocalcaneal arthrodesis, which is a fusion. He had an open reduction and internal fixation of his radius fracture and a lumbar fusion for his chance fracture. So 3 key points for acute compartment syndrome. One is it occurs when pressure inside a given compartment exceeds arterial perfusion pressure into the compartment, most commonly due to trauma. The diagnosis is primarily clinical, with pain out of proportion to exam being the best indicator of elevated compartments. And it is a surgical emergency treated with fasciotomy, and a shorter time to intervention correlates with better outcomes.